All right, so we're going to talk chapter 61, care of the patients with urinary problems. So the first one we're going to talk about is urinary incontinence, okay? It's an involuntary loss of urine, severe enough to cause social or hygienic problems, okay? Nobody wants to go out with somebody who's peeing themselves, okay, or smells like urine. So there are different types. On page 1327, figure 61.6, it talks about the different types of incontinence. So you have stress incontinence, urge incontinence, overflow incontinence, okay? Overflow, think of the urine is going, they're just making too much, okay? And then you have functional incontinence, which a lot of people I feel like live with functional incontinence, you know? They feel like they have to go, but they kind of wearing the depends, you know, just in case. Why does this happen? It could be temporary or permanent, could be caused from surgery, spinal cord injury, brain or nervous stem disorders, disease treatment, drugs, factors associated with aging. A lot of times you'll see this with your mommies that go through a C-section, all right? They take out the Foley, and then the mom's like, wait, I can't urinate. Something's wrong because of the anesthesia, the epidural. You know, it takes them a little bit more time for their body to like kind of wake up at that point. As many as 45% of women over the age of 65 report this condition. The risk increases with chronic condition, vaginal deliveries, pelvic prolapse, prostate problems, diabetes, heart failure, and obesity. Chronic problems is like stroke, cognitive impairments, impaired mobility, that they can't actually get up and use the restroom, you know, something's stopping them. The prostate problems, we know prostates are in men. So you'll do a history. You'll use effective screening methods. So you want to use the words always, sometimes, and never. That's how they should answer you. So do you urinate on yourself? Always, sometimes, or never. Okay. And kind of like circle, like they said always. I always, you know, I have more than 10 episodes of incontinence a day, always, you know. Sometimes they'll say, you know, sometimes they can't really recall. And then we go from there. You want to ask them, do you leak urine? All right, they're there for urinary incontinence. We need to know if they're just leaking or they're fully emptying their bladder without even knowing. Signs and symptoms, so you'll assess their abdomen. You're going to inspect females for prolapse, all right? There was a lady on my old unit, like, I don't even know how long ago, honestly, but she had her whole pelvis was prolapsed. It looked like she was delivering a baby at all times. It was literally straight out. But she didn't want to do repair. She said that they've tried in the past and the pelvic repair did not work. So now she no longer wanted to do it. But it causes incontinence issues. You know, she was all chaffed and raw from constantly urinating. The healthcare will provide comprehensive examination, which includes that distal rectal examination, the funnest part of their job. Lab assessment, they'll do a urinalysis to rule out a UTI. All right, somebody comes in and they're telling you, listen, I'm dribbling urine. You're not going to sit there and say, oh, sounds like you have incontinence. You're going to be like, wait, you have a little bit of urine coming out? Does it hurt when you go? Maybe you have a UTI. Maybe something's going on. All right. They will do a bladder scan to see how much urine this patient is retaining. A lot of times they'll ask the patient if they can, you know, can you please go urinate? And then we're going to do the scan to see what's left in there. A CT of the kidneys and the ureters. A VCUG is a voiding cystogram. All right, so that's where they'll get that contrast and they'll place it in and they'll watch how the patient is voiding and they'll take pictures to see if they're fully emptying the bladder. A lot of times, if they're not fully emptying the bladder, this is where your infection chapter comes back into play. Okay, if somebody's not fully emptying the urine out of their bladder, they're at risk for sepsis. Okay, holding that urine in. Urodynamic testing and the EMG of the pelvic muscle. So testing the strength of the pelvic muscles to hold the bladder and to release. Promoting elimination. So with urinary incontinence, they'll do nutrition therapy. Drug therapy, they may use topical estrogen because this may increase the blood flow to that area. Drugs that relax the smooth muscle. So a drug that they use very common is oxybutynin.
What is that for?
It relaxes the smooth muscle.
What is it called?
Oxybutynin. Devices, okay? A pessary, urethral plugs. We'll talk more about a pessary next week, okay? But pretty much it looks like a plug. And the body like contracts to it, okay? Yeah. Yeah. Electrical stimulation, again, to see how the muscles, to help with that muscle stimulation. Magnetic resonance therapy, that's where they put magnets, and the magnets are supposed to help with the contraction. Pelvic muscle therapy, everybody knows this, Kegels. Vaginal cone therapy, so that's where they take a cone, they insert it in the vagina, and the body will contract. And I've never seen these things in my real life, but resonance, yeah. So that's where they put a magnet, and it's supposed to contract on the magnet in your vagina. And then the most common one that you guys are used to, and the one that NCLEX really likes, is the behavioral interventions, okay? And that is, if somebody's incontinent, you're going to tell them, I'm going to get you up every hour. We're going to get up every hour. We're going to go to the bathroom. You're going to get them in that behavior so that they know that, and the body starts to get a hang of, all right, every hour I'm going to go to the bathroom, things like that. Another drug that they've been using lately, believe it or not, Botox. Yeah, because it strengthens that muscle.
Where do they use
in your muscle, in your urethral muscle. Yeah. Yes. Yes. Everywhere. Surgical management. They will use. Pre and post is on page 1334. Figure 61.2. 34. So a lot of times they will go in there and they will actually strengthen the muscle. So cut a little piece of muscle and kind of pull it back and strengthen it. With this, we need to pre-op. Obviously, a patient's going to need consent. We're going to teach them exercises after that, okay? You also want to tell the patient that if they live this lifestyle where they're doing the heavy lifting and stuff like that, they need to kind of calm it down, okay? Just until they're cleared by the doctor again. Post-op, they're going to come out. We're going to check their vital signs. Usually, patient will go home same day. Sometimes they will leave with a catheter. Okay, a lot of times, more recent ones, they haven't been. But if they do leave with a catheter, you want to teach them how to clean the catheter care. Okay. All right. Home care management. So you want to eliminate any hazards in the home. If they have urinary incontinence, okay, you don't want them roaming through the night going to find the bathroom. Give them a commode. All right. Males, if it's a male patient, give them. Why can't I think of the thing right now? I can't even think of what it is. Urinal. Hello. You want to give them a urinal to take home. You're going to teach about the specific type of incontinence and the management. So obviously, if it's stress incontinence, you want to tell these patients, you want to alleviate their stress, okay? Urge incontinence, that's more of the behavioral interventions, okay? Those are the people that need a schedule, all right? Because they have that urge, they're holding it in all day, and then they go to the bathroom, and then they have this incontinence, okay? Cystitis, this is inflammatory condition of the bladder. It usually refers to inflammation from infection of the bladder, and irritants can cause cystitis without infection. So who causes this? So more than 80% of UTIs are caused by E. coli. So a lot of times if a patient has a UTI, they will send that urine out for a culture to see how to treat it. Catheters are the most common. Catheters are the most common factor associated with new onset UTI in the hospital and long-term care settings. So that's a CAUTI, okay? And that's a catheter-associated urinary tract infection. So if a patient gets that, or maybe gets pressure ulcer, or develops ventilator-assisted pneumonia, their stay is free, okay? Because these are things that we can prevent, okay? If you provide the right catheter care to a patient, they shouldn't get a catheter-associated UTI, all right? How are you going to clean the catheter? Tell me. How do you clean a catheter? Right, so nearest to further, but think of it, keep it simple. What are you going to put in that? What kind of water are you going to use? Just soap and water. Mild soap and water, okay? Very simple. Don't get crazy. Soap and water, nearest to furthest, you want to remove all the gook, all right? The catheter bag, that Foley bag, do you just place it on the floor? No, you hang it on the side, okay? Patients ambulating in the hallway, catheter bag is here. What are you going to tell them? It happens all the time, every day. Every day. You got the family member walking around with it. And I'm like, sir, it's got to go down there. And then you see them 5 minutes later, like, you're going to tell them, because all that urine, it's going back. It's literally flowing back right in. That's it. Hello, cystitis. We're here. It's here. So you want to make sure that you're educating your patient, okay? It's not every day. It's not a common practice to the general public on having a catheter, urinary catheter. But we're trying to avoid catheter-associated urinary tract infections, okay? So we want to make sure. The reason why we tell the patient to not put the bag on the floor is because it's a permeable bag, meaning that there's bacteria on the floor. So that bacteria can get in that bag. And some would say, oh, who cares? The bag is whatever. But when you have the patient holding the Foley here, that the bag was just on the floor, everything's going back in. So you want to be very careful with that. Catheter care, can it be delegated to your PCA? Yes. Yes. Not catheter placement. Catheter placement is done with 2 RNs in the room because we want to make sure that we're maintaining sterility. Catheter care, you can have your PCA do it. I can say, can you do catheter care? And at the end of the day, say, hey, did you do catheter care? If they did it, great, amazing. If they didn't, it's still my responsibility. I have to go in there and do it at some point. If the patient's having multiple bowel movements, okay, catheter care has to be done every single time. It can't just be that one time, oh, I'm going to do it, but they're still having bowel movements. It's getting on the catheter. And then we have interstitial cystitis, okay? And that's more of an inside thing. Body's retaining, body is growing that bacteria. Incidence of UTI is the second only to URI in primary care. It's the most common healthcare associated infection. I just feel like where it's located, it's very hard to get around not getting something, you know what I mean? So we have to practice really good hygienic for these patients so that we can avoid this at all costs. Health promotion and maintenance, so sterile technique when inserting your catheters. Like I said, two nurses now because they want to maintain sterility. They want that nurse to be honest with that nurse and say, hey, you just broke, you should re-put on, let's redo this. Because let's say the patient, you break sterility and now you're putting in a Foley, they're going to get an infection, they're going to get a UTI. Clean technique when using intermittent catheters at home. So those patients who self-catheterize themselves, okay, that's a clean technique, meaning that the gloves that you have on the wall or whatever, those regular latex gloves or non-latex gloves, they can use, okay, those are clean technique. For the insertion of a Foley catheter in the hospital, it's sterile technique, okay? You got to understand how we use that. Single-use catheters are recommended for home settings. We had nursing, so CAUTI prevention. If they're in the hospital, we have to prevent CAUTIs, okay? Precaution. So like I said, warm soap water, okay? From the inner all the way out, okay? Whatever you see. You're not going to go inside the patient to get the catheter, okay? Whatever you can see, you just want to get that good schmutz, whatever you call it, off. And a liberal intake of water. We want to make sure that the patient is staying hydrated. A lot of times the patient will be like, oh, so signs and symptoms, these patients will have frequency, dysuria, urgency. What does that sound like? UTI. Fever, chills, nausea, may indicate infection, okay? Something's going on. You want to assess the catheter, okay? If a patient comes in through to the emergency room, let's say they come from the nursing home, right? And they have a catheter, we change the catheter in the emergency room. They do a catheter exchange, okay? Because we need to make sure that if that patient came in with an infection and that catheter is soiled or dirty, we're taking it out and we're putting a new one in. So a lot of times when you're getting report on the floor and when you guys are nurses and you get report, they will say, patient came in, they have a history of urinary retention or whatever the case is, has a Foley catheter. It was exchanged in the ED. Normal, okay? Because they come up to us. It's like a fresh start. We're not leaving them. We're not using that old catheter because I don't know if anybody has taken care of anybody in the hospital with like a nursing home catheter. The catheters look very different, all right? And sometimes they are different. They turn different colors, you know? So we take it out. We put hours where we can monitor it and we know what it's about. So they'll replace them. You want to have the patient void for the urine examination, meaning the examination of their urine. So that means just make them urinate in a cup. Vital signs, lower abdomen and bladder palpitation. The doctor will palpate, okay? We can inspect and note what their pain is. If you're doing a pain assessment, this is how it all ties back in. If you're doing a pain assessment, I don't care if it's a pain here, to here, to here, to here. What are you going to do? What are you going to ask them? On a pain scale, 0 to 10, what do you rate your pain? Where is your pain? What is your pain? God bless you. What is your pain like? What does it feel like? Things like that. Investigate the pain so that you have an accurate assessment of their pain. What do they say? Pain is what? The 5th vital sign? It's 1/6 vital sign? I learned that in nursing school. Never again. All right. Lab assessment, clean catch urine specimen. So this looks at the urinalysis, the culture and sensitivity. Patient goes to the bathroom. How are you going to tell them to do a clean catch?
Pee a little first. And then
right. First thing is they're going to wipe with those antibacterial things. Know that, guys. You got to know that for your final, okay? You have to know that. The wipe goes first, then they're going to pee a little bit, and then you're going to catch the urine, okay? Yeah. And that usually we take that and we take it to the lab after that. They will have, with cystitis, their white blood cell count will be elevated. There's an infection going on. It makes sense. Other diagnostic assessments, they'll do a pelvic ultrasound or a CT. They'll do a voiding cystourethropy. Why? Because they need to take pictures to see how much urine the patient is retaining. And they can even do a cystoscopy. What are we going to do for the patient? So non-surgical management, drug therapy. So you want to treat the bacteria and relieve the pain. They can give this patient fluconazole, nitrofurantoin, Bactrim, fosfomycin. These are like first-line drugs that they use. Now, if your patient is pregnant, if your patient is a man, sorry guys, or pregnant, they need a longer dose of antibiotics, okay? So men, it takes a little bit longer to get to, and women that are pregnant, we need to really eradicate this before a woman gives birth, okay? Fluid intake. You want to make sure these patients are getting 2 to 3 liters of fluid a day. Comfort measures, minimize the pain. All right, we want to make sure they're not having any bladder spasm. A little Tylenol, never hurt anybody. If they develop a rash with any of the antibiotics in life, what are you going to tell them? Stop. Exactly. You're not God. Stop the medication. Surgical management, they'll treat the condition that increases the risk for recurrent UTIs. Usually they'll do a cystoscopy on these patients, okay? Transitional management, we're going to assess the level of client's understanding. You're going to teach the patient, take the prescribed drug, okay? Take it with food, drink the water. Don't stop the medication until you're done. If it says 7 days, 3 times a day, you're taking it 7 days, 3 times a day. If you miss a dose, catch up. Address concerns associated with intimacy and reoccurring UTI. So a lot of times that happens. Patients will say, every time I'm intimate with my partner, I get a UTI, okay? And we definitely want to, address that with them. We want to tell them until they're done taking the antibiotics at a full course, then they should resume intimacy. At this time, they should really hold off, okay? Urethritis. It's inflammation of the urethra. It's the highest incidence of adults aged 20 to 24. An STI is the most common cause, okay? Symptoms include a sexually transmitted infection. Symptoms include mucopurulent or purulent discharge, mucus pus. Think of like mucus, like snot and pus in one, okay? Or purulent discharge, dysuria, and discomfort. So urinalysis may show pyuria. Everybody knows what pyuria is, the pus. When you look at the urine, it kind of looks like it has like a white ring around it. It's disgusting. You're going to test this patient for all STDs, STIs, sexually transmitted infections. You're going to tell the patient, here's the best part about this. It's going to resolve on its own. However, if they have a sexually transmitted infection, that's when we have to medicate them. Okay, we have to give them whatever they prescribe, whatever their STI is. It's resolved. Yeah. So if they test positive for it, we have to test it. We have to treat it.
But the urethritis will clear on its own.
Right, just by itself. Urolithiasis, fancy name, kidney stone. Okay. Presence of calculi in the urinary tract. The most common associated condition is dehydration, okay? These are so painful, guys. So painful. So we really want to help this patient because they're dying at this point. What are the risk factors? So we have who gets this, metabolic risk factors of dehydration, a family history, obesity, diabetes, gout, gout because of those uric acid crystals. Their diet, if they have increased sodium, increased protein. Yeah. It varies from geographic location, race, family, and history. A lot of times they come in, they'll either say like, my family suffers from kidney stones, or, I've changed my diet. I'm doing all this high protein, this crazy diet. And now I maybe didn't drink enough water or whatever it is. So the assessment, do they have a history of stones? Their diet history, like I said, they come in, they changed it. They're like, oh yeah, doing this crazy diet, and I'm only allowed protein and high fat or whatever the case is, and I'm allowed only a liter of water a day. People have like these crazy diets. Past treatment, if they had a stone, okay, how did they treat it? Did they need to go for surgery? Did they get it zapped? Were they able to pass the stone on their own? How is it treated? And recognize that the urinary tract obstruction is an emergency and must be treated to preserve kidney function, okay? So it's not something that you're going to sit lightly on. We have to move quick for these patients. Managing their pain. So non-surgical management, we'll do drug therapy. So an NSAID like Toradol will give them for the pain. They may need an antibiotic if they have any bacterial with it, if it's bacterial. Now, to open and help with the flow, the urinary flow. So if they do a CAT scan now and they see that they know that this stone could be passed, okay, and the patient can urinate it out, they usually give the patient Flomax. Okay, think of flow to help, okay? Flomax will help to pass that stone. Lithotripsy, another one is the zap. Yeah, is a zap. So the stone is big, but they zap it and that stone breaks, and so the patient could pass it. Now, what you're going to tell the patient for the drug therapy and the non-surgical, the lithotripsy, is that when they go home or whenever they have to urinate, they have to strain that urine. So we give them a little calendar. Surgical management. So minimally invasive surgical procedures, okay? So this is where they will go in, and they will kind of just try to get that stone right out, okay? They kind of do it laparoscopically, very easy. An open procedure, literally exactly the way it sounds. They cut so they can view the entire kidney. It's open. So sometimes you'll even hear like, oh, they were getting a laparoscopic appendectomy and it was converted to open, meaning that they were trying to go in laparoscopically. They couldn't see anything, so they had to cut them open. So pre-op, you're going to get consent. The doctor will go in there, explain the procedure, explain what's going to happen, okay? These patients will usually be MPO. If it's minimally invasive, it's same day. If it's open, they may keep them a night. Post-op, okay, patient gets up, we check the vitals. You want to monitor their intake, okay, and their output. You want to make sure that whatever's coming in, they're being able to process and take it out. Preventing infection. So these patients will be put on broad spectrum antibiotics. And preventing future obstructions. You're going to tell these patients to increase their fluids to 3 liters a day. All right, urethral cancer. So this is malignant tumors of the urolithium, lining of transitional cells in the kidney, renal pelvis, ureters, urinary bladder, and urethra. Bladder cancer. So exposure to toxins will increase the risk, and the greatest risk factor is tobacco. Health promotion and maintenance. So stop smoking. Use PPE around dry, liquid, or gaseous chemicals. Okay, so they should be using that PPE like whenever they're touching anything. And good hand washing. Shower or bathe and change clothing as soon as they come into any contact with any chemicals. So a lot of people, like, they go on their daily, they get exposed to these chemicals and then they just go on their daily day. Bring a set of change. You want them, tell them, bring change of clothes so that God forbid something happens, you can change. Same thing in the hospital. For the people who work like in the boiler room or the chemists or things like that, anything happens, they get anything on their clothing, they should be in PPE, but let's say it gets on their clothing, we have backup clothes for them. Like, it's not anything crazy, it's just scrubs, but still. So signs and symptoms, you want to ask about active and passive exposure to cigarette smoke. You're going to ask them about their hobbies and occupation. Ask them about change in urine habits and the presence of abdominal symptoms. You're going to look at their skin color, their nutritional status, and their abdomen. Remember, with the abdomen, you're just looking, you're not palpating it. Examine the urine for color and clarity. So usually when a patient comes in, right away, we lab them and we give them a cup, please urinate. When you go to dip their urine, you're going to look at the clarity, okay, and note if it's clear and the color of it. Psychosocial, you're going to assess their psychosocial status and coping mechanisms. Like I always say, everybody copes different. What works for one may not work for another. Somebody goes and runs, the other person needs to talk to somebody. Diagnostic assessment. So this is where they will go in and do a bladder wash specimen. So where they pretty much go in and they will wash the bladder out, not really wash it, but like clean the bladder out and take whatever specimens they collect and send it for cytology. Okay, when they wash it with a type of like solution that preserves those cells so that they can send it out. Bladder biopsy. Usually bladder biopsy is the tell-all, lets them know that the patient has bladder cancer, okay? Cystoscopy with biopsy, if they have a visible bladder tumor. They can do a cystouretography where they're using that contrast to watch the patient urinate. CT scans, they can do an ultrasound, MRI, but the telltale diagnostic test out of this whole thing is that bladder biopsy. Okay, they will take a biopsy of the bladder and it will come back and indicate that the patient has cancer. So interventions, non-surgical management. So they will do prophylactic immunotherapy with BCG. This is where an agent is instilled in the bladder.
Agent as in like
Like a fluid, yeah. So with this, when they put this in the bladder, you want to tell these patients that they should not share toilets. Men should sit and urinate, not stand because of the splash. They should wipe down the toilet afterwards. And no sex for 24 hours. Because of the agent. You don't want that agent to touch anybody else's skin. I know. Wait until we get to next week. They're in trouble. I'm kidding. Yes. Then they can use a multi-agent chemotherapy and radiation therapy, and you guys know that. Surgical management depends on the stage and type of cancer and the patient's general health. So pre-op, they will mark the site of where they're going to go in. They will tell the patient, okay, that it is a possibility that the patient is going to leave there with like an ostomy, okay, a fistula, all right, pending on how bad the cancer is, how bad what they're removing is. Post, all right, so if they have an ostomy, we know how to do ostomy care. They also may have a JP drain, okay? If they have a JP drain, remember a JP drain is that little grenade-looking drain, okay? How do you take care of that? You collapse it, exactly. You open it, you empty it, you collapse it. Remember that's the only way that it's going to draw everything out, okay? So nothing, you're not milking anything. You don't do anything. Now, how do we know that the drain has done its job? Like well, not even that. You know you'll know when it's done its job and it's time it's got to go when there's no output. There's no more output of it, okay? The drainage is no longer there, all right? It's drained everything from the inside that needed to be drained. So you want to teach them drain care. You want to teach them to record the output of it so that when they go back to the doctor's like, oh, it went from putting out 60 mLs every 4 hours to not even 5, for the whole day. Let's pull this, okay? Self-management education. So these patients will need to go for follow-ups. We can set those appointments up for the chemo, the radiation. Remember to teach them if they have that agent instilled about the toilet usage and no sex. And then here's your associations. Everybody loves these.